Hi, good morning, friends. Pradeep Pendyala, your buddy. Happy Sunday. Today I am going to discuss very interesting topic, that is obstetric hemorrhage. Any bleeding per vaginum after 24 weeks of pregnancy is usually considered antepartum hemorrhage. But before that, I would love to tell something interesting. Few hematological changes do take place during pregnancy. As you are all aware regarding the physiological anemia during the pregnancy, the percentage of increase of this thing plasma is huge, around 50%, whereas RBC do increase, but only up to the extent of 30%. So it comes to, although both the things are increased, it causes physiological anemia of pregnancy. Regarding plasma protein, interestingly, globulin do increase a lot, 10%, but albumin level goes down. Few things which do increase, especially those coagulation factors and fibrinogen level increase, anti-hemophilic factor do increase, Christmas factor and Stewart factor, Hageman factor do increase during pregnancy. And thromboelastin, antecedent and fibrin stabilizing factors do decrease. So that is the changes during pregnancy. And plasminogen level normally increase, and fibrin degradation, FDP, fibrin degradation products also increase. However, platelets, there would be no changes. So this is, with this background, we should consider and talk and discuss about obstetric hemorrhage. As I just mentioned, any bleeding from the genital tract after 24 weeks. Some people say even after 20 weeks of pregnancy, it could be labeled as antepartum hemorrhage. Placenta previa and abruptio placenta are the most common causes of severe hemorrhage. I am sure you know placenta is normally be implanted wholly or partially in the lower segment in the case of placenta previa. It could be placenta accreta, increta or percreta depending upon the implantation of the placenta. So that is it. Blood loss during surgery has to be prevented when placenta previa is in situ. And abruptio placenta usually is abnormal separation of normally placed placenta. But the bleeding occurs due to separation of the placenta lining from the uterus. This could be per vagina or it could be concealed or retroplacental. So that is the difference between abruptio placenta and placenta previa. Placenta accreta is a condition where the placenta is abnormally attached to the myometrium. Rarely blood vessels within the placenta or umbilical cord are seen within the fetal membranes, lowering. And that is it. One of the most important thing which has to be known is the clinical features, which could be, there could be abdominal pain, uterine tenderness, there could be change in the fetal heart, and there could be hypovolemic shock. So there may be requirement of maternal resuscitation along with emergency surgery for treating this condition of obstetric hemorrhage. Hemorrhage in the postpartum period is nothing but maybe continuity of what has happened in the antepartum period. Postpartum hemorrhage could be because of atony of the uterus or because of retained placenta or because of the trauma to the genital tract, or they could be coagulation disorders. So these are to be thought of. It could be mild blood loss when it is 500 to 100 ml of loss. It's moderate, around 1000 to, mild is 500 to 1000 ml, moderate is 1000 to 2000 ml, and if it is more than 2000 milliliter loss of blood during pregnancy, and delivery of the child is known as severe postpartum hemorrhage. So that is it. Normally, this thing, they could be cold periphery, they could be pallor, tachycardia, and hypertension. So whenever you treat such a patient, the goal should be to bring the hemoglobin level to at least 8 gram. And there should be at least 75,000 of platelets, and there should be at least fibrinogen level of 1.5 to 2 gram per liter. So this is the goal when you are resuscitating the patient. Interestingly, you have to see the urine output, you have to see the hemodynamic factors, hemoglobin, hematocrit, coagulation profile, like as I mentioned, platelet count, prothrombin time, activated partial thromboplastin time, and plasma fibrinogen should be monitored during this. Interestingly, thromboelastography and rotational thromboelastometry have been extremely useful in correcting coagulopathy. They are very, very effective. When you are using this blood products and when you are not sure about the blood group, go for O negative blood. And infusion of large volumes of crystalloids and colloids should be avoided because that would cause per se coagulopathy, metabolic acidosis, and tissue edema and tissue hypoxia. So you should not keep on pumping lots of colloids or crystalloids. It's better to give fresh frozen plasma and packed cells in the ratio 1:1. And whenever this thing, anytime, any operation theater, this obstetric hemorrhage can take place. So it is always recommended to have certain obstetric packs, transfusion packs, which should consist of 4 units of O negative blood, 4 units of fresh frozen plasma, and such things should be available. And platelets also should be available, preferably. And if it is possible, prothrombin complex and fibrinogen concentrate also to be available. Fibrinogen concentrates are normally, is very good. Fibrinogen is normally present in fresh frozen plasma, cryoprecipitate, and prothrombin concentrate also. And prothrombin concentrate complex can have factors 2, 9, and 10, and factor 8. Cell salvage is also can be considered, but may not be very effective because of alloimmunization, mixing of blood with the amniotic fluid and cell debris. So many people don't encourage this thing. However, American Society of Anesthesiologists have endorsed its use in postpartum hemorrhage. I must remind you, crystalloid and colloids during this obstetric hemorrhage can be infused, but large volumes should be avoided. Per se, it can cause coagulopathy and hypothermia. One thing which I must remind you all is the usage of tranexamic acid. It's a wonderful drug. It has wonderful anti-fibrinolytic drug, which is strongly recommended by WHO also. Please do use it, and preferably within 3 hours following vaginal delivery or cesarean section. Delayed use of tranexamic acid may not be beneficial. Calcium concentration also can be used safely, especially when there is a lot of massive transfusion has taken place. Normally, 10 ml of 10% calcium chloride after every 4 units of packed red cells should be administered without fail. There is a lot of controversy regarding recombinant activated factor 7, RF7E. It's very, very expensive. I personally don't advise it to be used. Latest guidelines, however, do not recommend the routine use of RF7A in the management of major postpartum hemorrhage. However, recombinant factor 7A promotes homeostasis at the site of the injury. It acts at the level of tissue factor dependent pathway and also via tissue factor independent pathway. And the factors 9, 10 are activated to form thrombin. And you are aware that thrombin per se would activate factor 5, 8 and 9 and platelets. So this is that. There could be surgical intervention also which can safely used for saving the patient severely bleeding postpartum or intrapartum during obstetric hemorrhage. And I would strongly recommend one is that is this thing. It could be manual removal of placenta or uterine packing, uterine balloon tamponade, and uterine compression sutures. Yes, this is also known as Lynch sutures. This I have used, and I'm not used, but I've seen being used. But